Good afternoon, everyone. I'm Melanie Escher with the Arizona Telemedicine Program and Southwest Telehealth Resource Center. Welcome to today's program. Next. So as you joined us today, of course, your phone or your computer microphone, they're muted, but please go ahead and use the chat function, which will be on the bottom of your screen for any Q&As if you've got for our presenter today. We have a few questions that were put into the registrations, and I've already passed those along to Carol, so she will address those. We've got a post-webinar evaluation, and actually this one does not have CME, but everyone will be able to get a certificate for this program, and that will be instructions for that will be in the thank you email when we are done. This is going to be recorded, and it will be on our website after everything is put together. Standard disclaimer. I'll let you read that. I don't need to read that out loud.
Everything I say is my own opinion.
Thank you. All right, next. And again, be sure to check our website for upcoming webinars and events. We're getting our training schedule for 2026 up and running. Then we'll have more webinars, of course, posted on our website. You can always sign up for our email newsletters and get our events emails. They come out every week, every other week. Next slide. And again, your opinion is valuable to us. Please go ahead and do that evaluation. It'll populate in a window behind the screen. Otherwise, I will also send it in my thank you email. So you don't need to worry about any of the URLs right now. All right, so without any further ado, I am going to introduce our illustrious billing expert, Carol Yarbrough, in her office hour style webinar, the CMS 2026 final ruling on the MPFS. Carol, go ahead and take it away.
Thanks so much, Melanie. Thanks for having me again. Yeah, and everybody that joined, just if you want to make this a conversation, we can make it a conversation. I have slides, but they're not necessarily I mean, they're important, but I put them in only because if nobody asked me a question, I wanted to have something to talk about. And yes, I am wearing a thick sweater today. Uh, it's cold in San Francisco. I know a lot of you are in a high desert there, and it's cold there too, wherever you are. So, um, things to remember. As mentioned, the slides will be provided after the webinar, and then the recording will be posted. Watch the recording a lot. I don't know if I mentioned this, but I was just crushed when I went and found one of my webinars on YouTube, and there was like 4 views. I was like, I am not famous on the internet. This is true. Anyway, and yeah, ask questions. Feel free to break in. It's a continuing conversation. Yeah, there aren't a whole lot of mysteries around telehealth for this year, but it's confusing. Everything's confusing nowadays. So I'm just going to give you the highlights. I go over some FAQs that actually CMS posted mid to late November, which are pretty amazingly good. And yeah, stump the presenter if you can. So here are the highlights. Uh, and a lot of this you'll say, wait a minute, did she already cover this? Yeah, I did. I covered it when discussing the proposed rule. And so these are everything as foreordained or predestined or talked about before. They've happened. Uh, there are a couple of things that we feared that did not happen, but most of it, uh, most of it passed muster with the people that read all the comments on that final rule. So as you know, the proposed rule published in July. You get 60 days to comment upon it. And so that lasted through about first week, second week of September. And then CMS is then reads all of the comments that are submitted to that proposed rule. And then they issue the final rule. And this was actually issued, it was actually issued on Halloween. So I did not read it on Halloween. I've just been kind of sidling up to the final rule this year. I don't know why. I just wasn't that excited about it. Probably because we're concerned about the continuity of telehealth. Okay, I'm just rambling again. So the conversion factor was increased by 2.5%. Sequestration is still happening. So then that meant the percentage rate went down. And there's an efficiency adjustment that's going on right now as well, not geared towards evaluation and management or psychology or anything that you would do via telehealth, but the better you get at a surgical procedure, the lower the RVUs. You know, this they announced this like it was anything new, but this has always happened. I think I mentioned last time too, like you go in and you have a cataract worked on and they take your lens out, put in a new one, and you can see again. Um, the RVUs on that has been coming down a lot over the years because the better and better the ophthalmologist gets at replacing those lenses, it doesn't cost that much anymore. The level of risk goes down. You're better at it. So pay you less. Makes sense. I guess. I don't know. I want to be paid highly for things that I'm really good at. Like, can you imagine Joshua Bell getting paid less because he's playing the violin better? No. Anyway, so, and as mentioned, we do have two conversion factors for both. I'm going to get rid of this for both the physicians and anesthesia providers. So, a qualified practitioner, which means a qualified practitioner is anyone who can engage in an evaluation and management service for this or bill Medicare with an NPI. Um, if you're an advanced practice model, and if you are, you know it, and if you're not, don't worry about it. You're going to get paid 17 cents less per relative value unit than if you were in an APM. So that's an incentive. Okay. All right. So to put this into monetary value, comparison from the current calendar year to January 1st. So conversion factor for the physician fee schedule, uh, $32.35 per relative value unit this year. So a non-QP, which means you're not in an advanced practice model, you get $33.40. If you are in an APM, it's $33.57. Anesthesia, it's a 10-cent difference. Now, anesthesia, I could, I could counter that. That would be a big difference because anesthesia is building units. Anyway, so to get your fee schedule and determine how much you're going to get paid for the region or the state you were located in, I believe everybody on this webinar is usually from jurisdiction F, which is Alaska, Arizona, Idaho, da da da. Um, this is Noridian Medicare, the Medicare administrative contractor. They've already calculated this for you. You don't have to calculate it yourself. You'll be like, what did she say was the conversion factor? And my gypsy means that's 1.8% times da, da. You don't have to do that. Oops, what happened here? You don't have to do that. You can go to the Noridian site and they've calculated it for you, which is fantastic. My jurisdiction, E in California, I love that they do this. What they did not do is have two fee schedules for APMs and non-APMs. So, like I said, if you're in an APM, you know who you are. You probably were like hand delivered a special conversion factor for being on top of your game. Okay, onward. That's enough about the conversion factor. I mean, at least I think when I started talking about telehealth services, the conversion rate was 30, almost $37 per relative value unit. Now we're down to 32 something. Uh, Note that again, because of budget neutrality requirements around the Medicare payments, we can't cost the Medicare folks, the Medicare bank account, more than a $12 million increase per year. And that's only $12 million, the entire nation. So that means the value has to go down in other codes. And I think they added 300 codes this year and only deleted a couple. So, yeah. So it's kind of like when, the Raven is putting in pebbles to get the water level up to a certain rate so they can get whatever is in that glass. I'm just trying to think of the fable. But for Medicare, we just want to keep those scales balanced. The Medicare telehealth services list, again, we know that for Medicare Advantage, things must be on the Medicare telehealth services list to be considered telehealth and fall under the rules surrounding telehealth uh, in order to build them out as telehealth. Medicare Advantage, some of the companies, the insurance companies that cover Medicare Advantage for beneficiaries, they can add things to that list, but they can't offer less. So, to get things on the list, one thing, make sure it's payable under the PFS. Don't put in a code that's something that the AMA made up and CMS has given it zero value. Maybe it's a category 3 code. So make sure it's separately payable. Make sure it's subject to the provisions of Section 1834M in the Social Security Act, which means it's something that could be conceivably done via telehealth over an audio visual modality such as we have right now. And then review the elements. Yeah. So just just submit your code, basically. There's no provisional anymore versus permanent. Remember, there used to be two categories like, oh, this is just on for the PHE, this is just on for forever. Now they're like, look, consider everything on the list permanent until we take it off. So I guess relax, nothing is constant. Just know if it's on there for this year, it's good for the year. It's not going to change. Um, and if you want to submit any codes that are separately payable under the PFS, you have till February 10th to do that. And if anyone's interested in submitting a code and they really want to do it, I'll I'll send you the email address. And there were some conversations in the comments for the Federal Register. Okay, I did read it, sidled up to it sideways, and then read some of the comments because that's like reading gossip. Um, like, okay, so why didn't we cover PIN or CHI codes for personal illness navigation or community health integration codes? One, they're not synchronous, and that's what meeting the Social Security Act provisions. These things all have to take in real time. This is real time coverage. PIN, CHI can be synchronous or asynchronous. So it's not going to be on the list because there are elements of it that can happen uh, in your clinician's office. Say you're the front desk worker and you do a lot of things and you're on the phone to the pharmacist and you're helping the patient with personal illness navigation, and you add that time to the code that can be billed for that service. That isn't happening face to face or ear to ear, real time with the patient. So that's why it's not Medicare telehealth. Okay. There are some additions to the list. Group behavioral counseling for obesity, GO473, 2 to 10 members. I can only imagine that's come out of the Make America Healthy Again initiatives. So that got added on. G0545, visit complexity inherent to hospital inpatient or observation care. So this is something that an infectious disease person can add on to any level of service they provide, either in person or via telehealth. So don't forget um, that this code already existed last year. Should have been putting it on all your infectious disease claims, all of them. Um, and and now you can do it for telehealth in the coming year. And then the added, which I think is lovely, multiple family group psychotherapy. So, meaning, uh, I talked about this code last year where, say, you're a family member and the patient has ADHD and or dementia. Let's keep it age appropriate for Medicare. Hopefully, if the Medicare patient has ADHD, everyone's figured out how to navigate that with that 70-year-old person, which I'm greatly rapidly approaching. But um so multiple families can all meet together to talk about how they're dealing with the family member with dementia. And that is billable via telehealth now, which is awesome. We got more codes. 92622, auditory osteo integrated sound processing. 92623, diagnostic analysis. So that gets listed in addition to the 92622. Uh, I would hazard a guess that this could possibly be billed by a primary care physician or someone similar because uh, if audiologists are not part of the eligible provider list after January 30th, even though these codes are on the list, who's going to bill them? I'm not sure. We'll get more to that later. My gosh, I'm trying not to grouse too much. All right. What changed for 2026 in addition to what I've already been discussing, cheerily? So, um, oh, okay, I'm gonna grouse a little bit. Remember the social determinant of health assessment test that could be given by either a clinician or someone in a clinic that the provider would then review and integrate into their evaluation and management visit. Uh, what was nice about the use of G0136 is that you would get paid $15 or so for that assessment that would be given, uh, questionnaire prior to the visit. Since it was determined that the SDOH concerns are probably already integrated into any kind of evaluation and management as the clinician is paying attention to what could affect the outcomes of care, unhoused, unstable, unstable, what is it? Housing instability, food source instability, refrigeration, types of things like that we've discussed in the past about what could make it difficult to maintain any kind of medicine regimen that would require stable storage, things like that. So they were going to delete the code, but they didn't delete the code because they gave it a new definition. So be careful. Be careful, be careful. It's still on the telehealth list, but be careful because now you're going to bill it when the provider or someone in the provider's clinic is going to assess physical activity and nutrition risk. Uh, so don't bill it when you're doing the social determinants, social drivers of health. That was redefined last year too. It's not determinants, drivers, social drivers of health. Because if you're doing that and billing G0136 starting January 1st, that's fraud in the government's eyes. Turn it around and I guess have your patients hop up and down on one foot and then talk about their diet. I know there are assessment tests and questionnaires relevant to these. I don't have I didn't look them up, but if anyone has an idea of what that might be, um, that'd be great. I guess the assessment would be like, do you go for a 20-minute walk every day? Do you go for a 40-minute walk every day? Kind of like those questions you answer, um, in your Apple Health app, whatever, to gain a baseline of whether or not you're adhering to your own activity level. Um, but I don't know what those are. I will find out and try to educate folks at my own institution where I work. But this is definitely something to pay attention to make sure that your staff is not performing or you are not performing the social driver of health assessment because now it's physical activity and nutrition. I wish they had changed the code and deleted it. Just whatever. Okay. So, what was added? So, I was excited about these codes last year. I don't know who's billing them. I'm going to have to do a deep dive into the CMS data warehouse. This is three codes that were provided, sort of like remote therapeutic monitoring for cognitive behavioral therapy. But in that instance, you only have to use a device as defined by the FDA. This has to be an FDA approved digital mental health service. So these G codes represent that. They've added ADHD to the behavioral health disorders that can be treated with these management service devices. Um, CMS also wants feedback about these uh, digital therapy devices. So just shoot them a note. Say, look, I have this. Um, I see you've priced it at such and such software as medical device, plus getting the FDA approval that took me 36 months, came up with these kind of costs. This is the return on investment that I want for these codes. Give your feedback about how much you think they're worth as an innovator. Um, This in particular, this finalized fee schedule, there are a lot of instances where CMS is still wanting input. So anything you want or you want to discuss, send them an email. Be very verbal with them or write-all. Okay. Virtual direct supervision. This is a big day. This is a big deal. And it's a big day. It's a big deal too. So, uh, if you're an academic medical center, you know there is no incident to at an academic medical center because we do split billing at hospital systems that are that large. So you have professional fees and you have technical fees. However, at a non-facility location, often physician services can be billed by uh, by them when their service is performed by their auxiliary personnel, meaning they have a direct contractual relationship to the physician, i.e., an employment contract and a paycheck, and then also working under the direct supervision. And then there's this PCTC indicator of 5, which means incident 2. They're not, they're bundled together. They're not separate. Um, these could be performed as long as the provider is virtually available. And that means audio, video, not just audio, but audio, video. Uh, Also, it includes services described by 99211. We know that that is typically an RN code. Um, Provider does not have to be in the clinic that day. So really great news for people that maybe have a couple of clinics travel in between. Okay, look at this question. Oh, Melanie, do you have any questions for me? No, they're all just being lulled to sleep and entranced. Okay. Uh, so what else changed again in inclusive of those incident 2 direct virtual supervision changes? And again, it says exclusive of audio only. They're saying any service that has 0 global days as well can potentially have virtual direct supervision. I guess that means stitching something up that doesn't have a 10-day global. Anything on the fee schedule that has 000 global days. They're thinking about endoscopy. I don't know about that. Like, I want a doctor. Doctor. But what's great too is for virtual supervision, for cardiac rehab, pulmonary rehab, and intensive cardiac rehabilitation. Say, you have the technician in with the patient at a treadmill, and the nurse practitioner, perhaps, that is supervising the rehab of that patient no longer has to be in the same building with the patient and the technician. Technicians probably monitoring the ECG, something like that. As long as that nurse practitioner or QHP, MD or DO is available via audio video, services can now be carried out. Fabulous. I like that. Oops. So, okay. So that's virtual supervision. Wait a minute. Did I want to talk about something else? Teaching physician. I might have forgotten a slide. Let me just talk about teaching physician. It could be in here. I'm not sure. It was late. For teaching physicians, it was going to be only for rural uh, cases. But for the teaching physician supervision, as long as the patient, the resident, the attending, if everyone's at their own computer, everyone's at their own station, virtual teaching can occur as well, virtual teaching supervision. Someone asked me recently if that meant, what about for primary care exception? Does the provider have to be in a separate place for PCE? My thought on that is after the 6 months where a resident no longer needs supervision for primary care exception, which is when you have a primary care practice, resident is supervised directly in person for 6 months. After that, they do great. They're set free. They can build mid-level codes, level 3, level 4 evaluation and management. Um, I would say if a resident is performing a virtual encounter with a patient who is at home and the attending is off supervising the other three folks in the clinic and not in the same room as the resident, because they don't have to come into the room anymore, that's fine. I think that's fine. That makes sense to me. Okay. RPM and RTM. There are new codes, and we have a friend we can thank for that. Um, well known to probably California Telehealth Network, maybe even Southwest TRC, but Robert Jaron championed these codes, brought them before the AMA twice. And at the second meeting, he prevailed. So let's all send him a thank you note for Christmas. We have here in the middle. Okay, so 99453, no change. That's the code. What's interesting about it is you can't bill it they said, unless it met the 16 to 30 days in a 30-day period, or after 16 transmissions. It wasn't married to the 99454. So what I love about this, because it's not married to that, but it did say, this is the education and billing guidelines had been interpreted. Okay, maybe I need to go back and figure this out for y'all. Seems to me if you meet the 2 to 15 days, you can bill the 99453 as long as it meets one of these codes where you can bill, where you've actually looked at data and you can comment upon it to the patient. Great. Someone had asked me what if it wasn't medically relevant to bill the 2 to 15 day data code? And I said, okay, so that doesn't matter because this is a practice expense code. The medical relevance would be discussed in this new first 10-minute code, 99470, or if you had to do a lot of activities around the patient not transmitting enough data, lots of phone calls, lots of one-on-one time. This is how you use your blood pressure cuff again. You can still bill all these other things. It doesn't matter if it's medically relevant or not. This is paying for a practice expense, software as medical device, as well as the device itself. So, um, don't worry about it till we get an audit. No, I'm kidding. Remote therapeutic monitoring also has two new codes. Let's see here. We got 2 to 15. Well, they got a lot of new codes because there's three modalities: musculoskeletal, uh, pulmonary, CBT. So there's four new codes. I'm sorry, I just lied. So sorry. Okay, so here's RTM for respiratory, 2 to 15 days. Again, I want to do a deep dive in the data warehouse because nerd, who's who's billed for a 98984? What's happening? Like what's the device? What's going on, man? Uh, I just don't understand what would be. Anyway, I know this was important during COVID, which is when this came up. Here's musculoskeletal, 2 to 15 days, which is great because, software is medical device plus the readings themselves being transmitted, that costs money, whether or not it's 16 to 30 days or 2 to 15. So you're getting some kind of reimbursement by implementing these services. The relative value units, the practice expense is pretty much halved. So, getting something. Something is better than nothing, or so they say. So here's your CBT, still contractor priced. Don't understand it. Um, Make sure you check the contractor priced billing fee schedules because that's a separate fee schedule, but the max are all somewhat equating these codes with the other codes. So I don't know what's happening with that, but you have to check that on another fee schedule, but they do pay. Let's see. And there's the 10-minute management code, like an RPM. So that's cool because maybe you don't have 20 minutes of stuff to talk about, unlike me, that can go 20 minutes on one slide. Okay. These FAQs were published uh, in, I want to say, mid-November as well, late November. I put the URL on the reference sheet at the very end of this deck. They're great. Anything you want to ask CMS or me about telehealth is on that FAQ. There's a lot of them. Talks about FQHCs, does not talk about pop music. I always think of that. Let's talk about pop music. But as you know, we're going back to the cliff's edge again. Collective sigh. Do Medicare beneficiaries need to be located in a rural area and in a medical facility in order to receive Medicare telehealth services? Uh, Not yet, but maybe. Again, the telehealth waiver extension was retroactively taken back to October 1st and goes through January 30th. I don't know why not January 31st. Probably has to do with 90 days. Yeah. Because we got the short month in there, September 30th. So, and November. Again, we'll be coming up against this uncertainty. Uh, but if your behavioral health, again, and I've reiterated this over and over the years, ever since it was codified, I want to say 2022, 2023, ever since it was codified into the Social Security Act, behavioral health, you're golden for the handful of you that are out there. We need more behavioral health providers. So we're allowing you to bill anywhere so we can work you all into the ground. Um, I would go back and get a psychologist degree, except I'm looking forward to retirement maybe in a couple of years. Uh, but it seems like a very viable profession to go into because you can do Medicare telehealth everywhere, anytime, anywhere. So, medical services, again, are on the precipice. And, okay, I did grouse a little bit about audiologists. Those two new codes that were put on to the Medicare telehealth services list might come off because if they do not approve physical therapists, OTs, SLPs, audiologists, again, where the respiratory therapists, where? Um, they will be off the list of eligible providers. I did not, um, there is a comment on the FAQ as well asking about diabetes management and RDs billing from a facility as an allied health provider, whether or not that would be allowed. It it's not contemplated, or it was not contemplated in the next version of the bill coming up. So that would mean auxiliary allied health providers in an urban area that usually bill out on the UBO4, which is the facility bill, they will no longer be allowed to provide telehealth services. And this was not an OPPS. So I was surprised when these providers were added in to the extension that went back to October 1st. Um, so we'll see what happens in the next version, because OPPS did not include these providers as telehealth providers. And I think they did it last year because they were tying together all the services that were still being extended through the end of this year. So pay special attention to that if you have these providers, including diabetes management, RDs. Pay special attention to what's going to go on with the ability to provide these services. Now, if they approve them again for the coming year, that means if these are providers that have their own NPIs and their own businesses, usually, they can continue to provide telehealth services if they are included in the next version of the extension of the telehealth waivers. Um, Pay attention. So pay attention if you're in a facility. That's all I'm saying. That's all I'm saying. Okay. What about FQHCs and RHCs? Can they continue to serve as distant sites? Behavioral health? Yes. And then through for non-behavioral through the end of this year, Bill G 2025. So it remains to be seen um, coming up on the next set of waivers as well, uh, what's going on for FQs and RHCs. I can't imagine it would not also be continued. I thought this was interesting. Behavioral health is paid under the AIR and the PPS, but RPM is no longer that one code. Those are individual codes. So I don't know, I thought it was interesting. All right, enrollment. People have been upset, excited, concerned about provider enrollment. Uh, for me, I've been concerned about provider enrollment and what to report in box 32 since I was hired into the Telehealth Resource Center at UCSF in August of 2015. I'm trying to figure out what to put on these bills since then. This is clarity. This is clarification. Okay, so my day job, I work at a facility. It's a hospital that provides hospital outpatient department services. So, providers, practitioners at my facility have a regular clinic address where they would usually see patients. Uh, there was some talk, someone mentioned 8-hour days versus 2 hours, three, whatever. The rule of thumb on this should be if you work 100% from home, but you still are affiliated with that clinic as your employer, you get to have the practice location represented on box 32. They also stated you're not required to report that home address on the Medicare enrollment application. I would imagine that CMS and the beleaguered PICOS, uh, people reviewing all of the enrollment applications were thinking, oh my gosh, there are thousands and thousands of providers affiliated with facilities that sometimes see patients from their home address. How are we going to process all these applications? So, so for virtual only practitioners, there's still a privacy concern. People are still not excited about this, but the physical practice location is their home address. And then you mark the address as home office for administrative telehealth use only. Now, while that address does go on the CMS 1500 into box 32, the street address, at least, is suppressed on your profile page with the CMS Care Compare website. I don't know how many patients, beneficiaries actually ever see a CMS 1500. I don't know what explanation of benefit address information will be included on the EOB after January 1st. These are some things to consider uh, when you're enrolling your providers if you're a virtual only vendor. So there was a question about advanced primary care management. Now, this seems really administrative in nature. And if your clinic has the bandwidth for someone to take over the reporting, so it's a little bit like chronic care management, principal care management, any of these management services, they're really heavily administrative in nature. Uh, Tallying times, tallying what was done, who did it, what day. If you have a vendor or if you have the bandwidth, again, if you have the bandwidth in your clinical staff for someone who's going to make sure the billing guidelines are met for this yet another care management service, which is highly, heavily administrative in nature, check out that URL. There is a PYA webinar as well that was presented by a Foley attorney. PYA and Foley? Are they mixing and matching their attorneys? Very good webinar on APCM. And if you are a fan of the Coding Intel website, there is an APCM guide on there with any of these services, not for the faint of heart and not to be trifled with, because there are, there are consents to be obtained. There are copays to be collected monthly from the Medicare beneficiary. Um, and you have to document what you're doing, by whom, and what was happening. So good luck with that. I I would not recommend it. I maybe it's easier than I think. Maybe I'm just getting kind of curmudgeonly. Um, of course, we'll be sharing the slides. And is there any site limitation for using primary care exception? Uh, so currently, Hillary, there is no site limitation, rural, the geographic site, rural versus medical statistical area for using primary care exception. There will be as of January 31st if if um if we don't get an extension. So it's the same deal. Um, if that resident is providing services to someone in a HRSA eligible site, then yeah, that can be allowed. But for within a city, no. Uh, Hill insiders have indicated that there will probably maybe be another short shutdown uh pending the new budget to be approved as of January 30th so that the feds have money for January 31st. And telehealth will have either a 2 or a 5, between 2 and 5 year extension with that new uh, continuing resolution, with the new bill information, the new funding bill. So fingers crossed that that won't be anything we have to worry about. But during that shutdown again, probably won't last 2 months. The last shutdown was the longest in history, probably will not be replicated. However, uh, again, hope for the best, prepare for the worst. If you need to quickly flip over your patients, if for some unknown reason telehealth does not get continued, um, you have to figure out what financially you can do and what risk you're going to shoulder if you're going to wait for them to retroactively. Are they going to retroactively approve payments this time? Okay, so here's the fabulous FAQ. That's the number 2 here. And if you're like me and you like reading comments and like people talking about each other's comments, kind of like office gossip, but in the Federal Register, go ahead and read the final rule. Fascinating. They're like, oh yeah, so and so said this, not by name, but like people indicated da 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 da. I don't know. I think it's kind of fun. It's like people talking about each other. I'm I wouldn't say I'm a gossip. I'm not impartial to clicking on links that are provided to me when I'm just trying to look up APCM and then something will come up about you won't recognize this star from the 80s. Here is a really good just summary of the fee schedule for this year. Uh, and that's it. Here's the new telehealth list. And I think that's it. If we don't, let's see if we have any questions.
We
Okay,
have,
CMS,
yeah, we have one more question in there.
yeah, FQHC, CMS laws G 2025. Do we have to submit the level of E&M? No. The revenue code is 780 for telehealth. So, all right. Yeah, you're welcome, Estrella. Uh, so I hope, after you've listened to all the other webinars, I hope I was able to fill in some gaps and create reinstill anxiety in you while we wait for the next telehealth cutoff. I
So,
don't know. I'm just really hoping for that 2 to 5 year extension. Just come on. Just 2 years. It's all we want. And then within 5 years, I'll be on Medicare. So then I can worry about it then. But in the meantime, it would be nice to, as a revenue person, to not worry about it.
We have one more comment to how about how audio only seems to be still confusing.
Oh, okay. So audio only. Um, if you can give, if the patient for medical and behavioral health, if the if the service can be done audio only, you can bill it, but it has to be at the you have to document in the note that either the patient wanted it, technology failed, and as a provider, that you are able to give that service via audio video, that you're not prescribing that it can be audio only because you don't have video. So it has to be at the patient's preference or at their technology limitation. But currently, uh, audio only for evaluation and management is fine. Put your modifier 93 on there with POS 10 if patient's at home, patient's in a facility at O2. Yeah.
All right. Doesn't look like we have any other questions. I do want to let those that are still with us know that Carol is going to be on our training staff this next year when we do our developing a telemedicine program trainings. We've got those dates are already up on our website and you can register for that. So she'll be doing some frequent updates on billing and for telehealth and telemedicine during our training program. So a little plug for Carol, adding her to our uh, our training
I feel so
staff.
loved. I'm loved.
You will become internet famous soon enough. We'll get those YouTube
Yes.
video visits up, right?
Ugh.
All
All
right,
right.
so if we don't have any more questions, we're just about at the end of our hour. Again, program has been recorded and the resources will be available on the website with the recording at a later point in time. We've got the slides for you. And you'll be able to click on these links and be able to get any other information that you have. If a question comes up after this webinar and you would love to ask Carol, please go ahead and send us an email and we will get it forwarded to her so she can answer that for you. So without any further ado, I guess we're going to go ahead and call it a day. Thank you for joining us, and we look forward to seeing you at a future event and webinar and training, and have a great holiday season, everyone. Thanks,
Thanks.
everyone.
Bye-bye.